Hello, class, and Dr. Donald. Montana, thank you for that compelling opening. While I appreciate the concerns raised, I must respectfully disagree. The assertion that mandatory overtime universally threatens patient safety, healthcare provider autonomy, and long-term staffing fails to account for the complexities of real-world healthcare delivery today. In this rebuttal, I will argue that mandatory overtime, when used appropriately and supported by systemic safeguards, is an essential mechanism to uphold patient safety, ensure continuity of care, and maintain a resilient healthcare system, especially in times of crisis. The three con arguments made by my opponent are argument number one, mandatory overtime compromises patient safety and quality of care. Argument number two, mandatory overtime threatens professional autonomy and patient responsibility. And argument number three, worsens workforce retention and workplace sustainability. So we're going to delve into each one of these in more depth and analyze the argument. Let's begin by addressing the issue of patient safety, my opponent's first argument. The con side argues that overtime automatically leads to errors. However, this perspective oversimplifies the research. While fatigue can increase the risk of mistakes, the relationship is not linear or absolute. A 2020 study published by the Journal of Nursing Administration by Stimfeld and colleagues found that work environment quality, not just the hours worked, was the most significant predictor of patient outcomes. In well-supported environments where staffing levels are flexible and breaks are honored, the negative effects of extended shifts can be mitigated. The argument made by my opponent, supported by articles like Statistics in 2022, was a blog from AMW Healthcare. This contains a strong narrative statements, but it does lack the rigor of a peer-reviewed data. While they might highlight individual stories, they don't provide strong empirical evidence for policymaking. In fact, mandatory overtime when used strategically can prevent even more dangerous consequences, like staffing gaps that leave patients unsupervised or rushed handoffs between unfamiliar providers. In emergency departments, trauma units, or rural facilities where there's no float pool or backup staff, requiring an experienced nurse to stay an additional 4 hours could prevent a critical lapse. In those moments, mandatory overtime is not the enemy, but it's the lifeline. Now, let's address argument number two made by my opponent regarding professional autonomy. Autonomy is a cornerstone of nursing ethics, but autonomy does not mean complete independence from organizational or public health obligations. The Canadian Nurses Association in 2017 clarifies that nurses have a duty to provide care during emergency situations, even when this involves personal risk or hardship. This includes pandemics, natural disasters, and yes, staffing emergencies. In regulated professions, autonomy always coexists with collective responsibility. A nurse's self-assessment of fatigue is of course important, but not infallible. This must be weighed against the realities of healthcare and the risks of other staff or patients. We must also acknowledge that employers have a legal and ethical obligation under provincial and federal regulations to ensure patient coverage. When staffing shortages threaten patient lives, the organization must have a mechanism to require coverage, or they risk breaching their own duty of care. While the AGN article brought forward by my opponent by Trossman in 2005 raises concerns about overtime, it is nearly 20 years old. Since then, policies around rest, shift caps, and recovery time have been improved significantly, especially under regulatory frameworks like NAMB. Using this as the foundation for today's argument overlooks decades of system improvement. Similarly, the arguments drawn from Worthington and Ulmer, Worthington was in 2001 and Ulmer was in 2002, reflects fears based on very different healthcare era. Today we have robust protections and increased attention to safe scheduling. The legislation they describe was designed for unregulated or exploitation conditions, not the structured, last resort mandatory overtime we're debating today. According to the Nurses Association of New Brunswick Code of Ethics, nurses are professionally and ethically obligated to provide patient care during emergency situations, similar to the Canadian Association of Nursing. In these scenarios, the employer has a parallel responsibility to ensure care is delivered, and mandatory overtime provides a last resort option to uphold that duty. Contrary to the portrayal that nurses being powerless, most collective agreements already contain safeguards for overtime practices, such as maximum shift lengths, rest periods, and opt-out clauses after critical incidents. For example, NAMB's guidance supports regulatory protections include maximum hours per shift, post-overtime recovery periods, and processes for avoiding concerns about unsafe conditions. The idea that nurses are being coerced without recourse is inaccurate in the New Brunswick context and Canadian context, where such safeguards are established through collective agreements. Autonomy exists within a framework of accountability to patients, the profession, and the public. Now on to the third point raised by my opponent, that mandatory overtime worsens recruitment and retention. Here again, context matters. It's not the occasional mandatory overtime shift that causes nurses to leave. It's the lack of systemic support. A 2022 study in health services research by Dalora and colleagues emphasized that workload predictability, perceived fairness, and supportive leadership were more influential in retention than hours worked alone. Nurses are most likely to leave the profession due to chronic understaffing, disrespect, and lack of input into decision making than the presence of mandated hours during emergencies. While my opponent brought up the article Bay in 2024, which identifies associations between overtime and burnout, the study is a cross-sectional in design, meaning that we cannot conclude that mandatory overtime alone causes burnout. In fact, the author also points out the broader systemic factors like chronic understaffing that play a much larger role in dissatisfaction and turnover. Mandatory overtime, when transparent, compensated, and rare, does not necessarily erode morale. In fact, during crises such as COVID-19, many nurses willingly worked extended hours to meet community need, as highlighted in the International Nursing Review by Terrell and Nantersprat in 2021. The issue is not the mandate itself, it's a lack of investment in a broader staffing solutions. If mandatory overtime were banned altogether, what happens when 3 nurses call in sick and no one volunteers? Do we close wards? Do we delay chemotherapy or trauma surgery? That's not sustainable or safe. And finally, let's consider the ethical question raised. Is it right to require nurses to keep working when they are tired? No, this is not ideal, but it is more ethical to leave patients unattended. The answer is not always clean-cut. Healthcare is full of ethically gray situations, and as nurses, we are trained to navigate those tensions, not to avoid them. Sometimes the ethical imperative to protect life and provide care requires us to stretch our capacity, but only if the system supports us when we do. This is not simple nurse versus hospital issue. It's an ethical balance between workers' right and public safety. Exhausted nurses should never be the norm, but in an emergency, staying an extra 2 to 4 hours may be the most ethical choice available. And employers need the legal right to make that call when no other option exists. The solution isn't to ban mandatory overtime, but it's to regulate it, use it sparingly, and invest in longer-term staffing solutions. The Canadian Nurses Association and NAMB both stress the importance of building resilient systems that support ethical care. But resilience includes flexibility, and sometimes mandatory overtime is the only way to protect patients. In closing, let me be clear. I am not arguing for routine abuse of staff through endless overtime. I am arguing that eliminating the right of employers to mandate overtime removes a critical tool in ensuring patient safety, system responsiveness. Instead of outlawing mandatory overtime, we should only limit its use in true emergencies, ensure fair compensation, respect maximum shift limits, provide recovery time afterward, invest in recruitment, and flexible staffing pools. Mandatory overtime, when regulated properly, is a fail-safe, not a failure. The alternative is gaps in care, delays in treatments, and preventable deaths is far worse. We must balance the right of workers and the rights of the patient. It's not a choice between safety and staffing. It's a matter of us using all the available tools responsibly, and that includes the right to require mandatory overtime when absolutely necessary. Mandatory overtime, when governed by policy and used only in necessary circumstances, is not a betrayal of ethics. It's a mechanism to uphold them. It ensures that patients are not abandoned, units remain safely staffed, and care continues in the face of system strain. Eliminating this tool would leave employees and patients vulnerable in times of greatest need. Let's not confuse occasional necessary mandates with systemic abuse. What we need is fair, ethical implementation, and not outright rejection. Please take a look at my list of references here, and thank you so much for listening. I look forward to continuing this conversation.